Your body is shaking. You haven't slept in 3 days. The thing that would make it stop costs $12. And you don't have $12. This is what addiction feels like at the very bottom. Not a choice, not a moral failure, a body in crisis with no mechanism to pay for relief. What happens next is not determined by the severity of your addiction. It is determined by the number in your bank account. This is how you are treated as a drug addict at every level of wealth. You are stopped on the corner. The officer recognizes the signs, the eyes, the posture, the location. You are searched. The small amount on you, enough for one day, not enough to matter to anyone except the officer writing the charge. It becomes a possession arrest. You are handcuffed, not hospitalized. The jail you enter tonight has no detox program. There is a doctor on call, technically, but the withdrawal that begins in your 3rd hour inside will not be treated with medication. It will be observed. You will shake and sweat and vomit on a concrete floor. The guard outside will note in a logbook that you are in withdrawal, and that note will become the full extent of your medical care. 65% of the incarcerated population in the United States is addicted to drugs or alcohol. 11% of them receive just anyhow treatment. The remaining 54% complete their sentence, are released to the same environment that produced the addiction, and return within 3 years at a rate that justifies building more prisons instead of fewer. The United States spends more than $80 billion on prisons every year. It spends $8.9 billion on substance abuse and mental health services combined. The math is not an accident. You leave jail with a possession charge on your record. The record makes it harder to rent an apartment. The apartment you cannot rent makes it harder to escape the neighborhood where your addiction began. The system does not appear to understand the connection. Or it does understand it and has calculated that your situation is less expensive to process than to solve. You are not a patient at level 0. You are a case number, processed, filed, and released back into the same conditions that made you one. You are functional, if that word still applies. You hold a job, not one that requires a background check or one where people look too closely. You use in the evenings, sometimes the mornings. You have not been arrested because you do not use in public and you do not buy in volume. You look up Rehab. The cheapest 30-day inpatient program you can find starts at around $6,000. The national average is closer to $13,500. You do not have either. You look up outpatient options. The county program is free but requires an intake assessment. You call. You are placed on hold. You call again the next day. The intake process takes longer than the crisis that prompted it. You stop calling. You go to the emergency room on a Tuesday because something went wrong. The dose was wrong, or the supply was wrong. Fentanyl is now present in the majority of illicit drug supplies across the United States. In some cities, it has been detected in over 90% of street opioid samples tested. People who die from it rarely knew it was there. The ER treats the immediate crisis. Narcan, fluids, monitoring. You are stable within 4 hours. Before you are discharged, someone comes to your bedside. Not a social worker, not a counselor, a clipboard with a list of phone numbers. You are told to call when you are ready to seek help. You ask what that means, when you are ready. The person does not explain. The clipboard is the discharge plan. You call 2 of the numbers that week. One is disconnected. One has a 6-week wait. A person making $20,000 a year is 1/3 less likely to recover from cocaine addiction than someone making $70,000. The gap is not willpower, it is access. Lack of financial resources or insurance is the most commonly reported reason Americans do not receive treatment. 37% of people who needed care and did not get it said this was the reason. You are not refused care at level 2. You are given care that stops just short of working. You qualify for Medicaid. This is the line where treatment becomes possible in ways it was not below it. Medicaid covers substance use disorder treatment in most states. You find a covered program. It is an intensive outpatient program, 3 hours a day, 3 days a week. You arrange your work schedule around it. You attend. The counselor who runs your group has 42 clients. She knows your name. She does not always remember the details of your situation when you check in. The group is large enough that silence is easy. The people in the room are at different stages, with different substances, different histories. What you share is the program. The program is the same for everyone. You are given Suboxone. This is the medication that reduces cravings and withdrawal, a tool that research shows reduces the risk of opioid overdose death by between 38 and 62%, depending on the study population and duration of treatment. You take it. It helps. The prescription requires a monthly appointment you attend alone, in a waiting room with fluorescent lights between your work shift and the program's hours. You complete the program. Your counselor gives you a handshake and a list of AA meetings in your zip code. You leave with no aftercare coordinator, no follow-up therapist, no prescribing psychiatrist for the underlying anxiety that your addiction was managing. You leave with a list of community resources and your own willpower. Willpower is not a clinical tool. It does not have a consistent efficacy rate. It performs differently depending on sleep, stress, social environment, and access to support. None of those conditions were improved by the program you completed. At level 3, the system offers you a door. It does not ask what happens after you walk through it. Your insurance covers inpatient treatment, not without a fight. The initial request is denied as not medically necessary. Your doctor submits a clinical letter. The insurer requires a peer-to-peer call between your doctor and their medical reviewer. The call happens. The claim is approved for 28 days. You take 28 days of leave. Your employer is told you have a medical situation. You go to a real facility. There are individual therapy sessions twice a week. There is a psychiatrist who evaluates you on day 3 and prescribes medication for the anxiety diagnosis that took until this moment to receive. There is group therapy, and the group is smaller, and the counselor remembers your name and your file. The 28 days end because your insurance has decided that 28 days is what you need. Not your doctor, not your counselor who told you she would have recommended 60 to 90 days. Your insurer's actuarial model determined the approval window, and the model is not based on your outcome. It is based on the cost of the claim. You go back to work on day 29. You are not ready. You know you are not ready. Your counselor knows you are not ready. Your insurer does not ask. The relapse rate for substance use disorders is between 40 and 60%. That is not a failure of patience. That is a failure of an approval window designed around a payment calculation rather than a medical one. You are treated at level 4. The treatment is real. It is also too short, and everyone involved knows why. You pay out of pocket. You have done the research. You know that 60 days is the minimum for durable outcomes. You know that individual therapy and psychiatric co-treatment outperform group-only programs. You find a private facility, not the most expensive, but serious. 60 days, $28,000 paid by wire transfer before intake. The facility has 10 clients. Your therapist has a caseload of 4. You meet with a psychiatrist weekly, not once at intake. There is a nutritionist because what you eat affects neurochemical recovery in ways the county program was not funded to address. There is structured somatic therapy. There is time. Time is the resource that treatment requires most, and money most directly purchases. 2 months away from work, from the environment, from the people and the places that exist inside the ordinary day. 2 months without the triggers the ordinary day contains. Your employer knows. You told them carefully in a meeting where HR was present and the conversation was framed around the company's employee assistance program. They responded professionally. You are not fired. You return to your position without incident because the company has calculated that replacing a $200,000 a year employee is more expensive than holding their position for 60 days. You leave with an aftercare plan, a weekly therapist, a prescribing psychiatrist, a sponsor, a sober community, a safety architecture built around the knowledge that early recovery is not the same as completed recovery, and that the environment you return to is the environment that either supports or erodes what the 60 days built. At level 5, recovery is designed, not hoped for. The facility has a name people recognize. Passages, Malibu, the Betty Ford Center, Cliffside. Names that have appeared in magazine profiles and in the acknowledgments of memoirs. The cost at Passages is $80,000 for 1 month. The cost at Promises Malibu is $120,000. You do not negotiate this. You transfer funds and arrive. The program is built around your specific history, your specific substances, your specific neurological profile, your specific life. The lead therapist has worked with high-functioning professionals for 20 years and knows the difference between an addiction that developed from chronic pain, one that escalated from recreational use, and one that developed from something that happened earlier that you have not yet told anyone about. She begins with that question. You have a private room with a view. A chef prepares your meals. These are not amenities inserted to attract clientele. They are factors in outcome. Sleep quality, nutritional support, and sensory environment all affect neurochemical recovery. Every detail of your stay has been considered in that light. Keith Urban entered a rehabilitation facility in 2006 after his wife, Nicole Kidman, told him he had to choose. He has said publicly that it was that decision that saved his life. He was treated by people who knew his history, understood his specific situation, and had time for it. He has been sober since. He is one of the most successful country musicians alive. You leave with an aftercare coordinator who will call you every week for the next 6 months. If you relapse, she will answer the phone. At level 6, you are treated like a person whose recovery matters to the institution even after the billing period ends. The facility is not listed on any website. Your attorney made the call. The name was passed through a referral that does not exist in writing. The waiting list for places like this is managed by relationships, not by online submission forms. You arrive. The client list is sealed. The staff have signed non-disclosure agreements. Your publicist has already prepared a statement about a health sabbatical in case the absence from public life generates questions. It will not generate questions because the people who know where you are the people who arranged it. Your treatment team is assembled for you, a psychiatrist who has published research on dual diagnosis, an addiction specialist whose other clients include people you have met at industry events, a somatic therapist, a nutritionist, a trainer who understands addiction physiology. They meet weekly to discuss your case. Your case is the meeting. Philip Seymour Hoffman was sober for 23 years before his relapse in 2012.
Is it drugs or alcohol or both? Yes, all that stuff, yeah. Anything I can get my hands on. Yeah, I liked it all, yeah.
He had resources. He sought treatment in 2013 when the relapse became a crisis. He was found in February 2014 with a needle in his arm. He died at 56. His death was reported as a tragedy, as a lesson, as the loss of a great artist. The death of someone with the same substance and the same disorder at level 1 in the same city that same winter was a data point in a public health database. The difference between those two outcomes was not the addiction, it was the noun assigned to each person. One was an artist, one was a statistic. At level 7, the noun assigned to you is still a person. You don't go to a facility, the team comes to you. Your residence is prepared, a live-in psychiatrist, a round-the-clock nurse, a therapist who adjusts her schedule to yours. There is no intake form because there is no institution. There is a staff, and the staff's only patient is you. In July 2018, Demi Lovato was found unconscious at her home in Los Angeles. She had overdosed on fentanyl-laced heroin. Paramedics administered Narcan. She survived. She was taken to Cedars-Sinai Medical Center, where she spent nearly 2 weeks. The overdose had caused 3 strokes, a heart attack, and organ failure requiring dialysis. She left with permanent neurological damage that affected her vision and hearing for the rest of her life. She also left with a treatment team, a documentary, a platform, a career that continued and, by certain measures, expanded. Her addiction became a story of survival. The story was told on her terms in her documentary to an audience of millions who received it as inspiration. Robert Downey Jr. was arrested in 1996 for possession of heroin, cocaine, and crack cocaine on Sunset Boulevard. He spent 113 days in Los Angeles County Jail. He was sentenced to 3 years in state prison, served 12 months, was paroled, and was arrested again in 2001. The courts eventually directed him into rehabilitation under California's Proposition 36, a law that routes non-violent drug offenders toward treatment rather than prison. He entered Wavelengths International. He has been sober since 2003. He earned $75 million from Avengers. End game alone. His story is told as a comeback. The story of the person next to him in that county jail, who had the same substance and the same disorder, and no version of Proposition 36 applied to their case. That story is not told anywhere. The addiction was the same. The system that processed each of them was not. At $10 million, your addiction becomes a chapter in a book someone will eventually write about you. The insight you developed during recovery becomes content. The treatment that saved your life becomes a cause you fund. The lowest point of your life becomes the most meaningful paragraph of your public biography. The system was never built to save everyone. It was built to process most people and transform a few. The ones it transforms are the ones who can afford to be transformed. At level 0, your addiction is a crime. At level 2, it is an inconvenience the system documents but does not resolve. At level 4, it is a covered condition, treated briefly, released early. At level 6, it is a private matter, handled with discretion and resources calibrated to your outcome. At level 8, it is a narrative arc, and the arc bends toward redemption. The addiction is the same at every level. Right now, someone is shaking in a county jail with no detox bed. Someone else is in a private room in Malibu with an ocean view and a chef and a therapist who has read every page of their file. They have the same issue. The treatment they receive was never determined by what they needed. It was always determined by what was next to their name.